Hey there, just give me 1 second. I'm trying to get the the PowerPoint that I made to be showing up here, and Google Chrome is not playing ball here. Change some settings so I could share my screen. Okay, looks like it worked this time at least. Good deal. All right, well, I really am excited to share this paper. So I can't say that I've become an expert in the weekend over it, but I did kind of create my own PowerPoint to way to present this to you all. And depending on how long it takes to actually get through this, we may have to do a couple sessions because, the paper is pretty long. As a matter of fact, let me pull it up real fast. The paper is 50 pages. And to be fair, probably half of that are references. And then there's actually a bunch of stuff that's not in the initial 50-page paper, that a bunch of supplemental materials. There's like 7 supplemental documents. And so that's why I just created my own PowerPoint. That way I could kind of highlight things, kind of like show things in a way that makes sense to me, hopefully makes sense to you as well. And then I've actually included the supplemental materials to this, so that way we can see everything that was presented. So this paper just came out a couple days ago, December 5th, 2024. And so probably a lot of you have been waiting for this paper a lot longer than I have. I'm fairly new to the space. I would say, I kind of got into really deep into the cancers and metabolic disease probably like February, March of this year, and was focusing mostly on mitochondria before that. And obviously this dovetails nicely into it. But, some people maybe who've been following, Thomas Seyfried for a long time, maybe have been waiting for this paper for years. I mean, I'm pretty sure he's been in a lot of his podcasts talking about this paper, as the paper that's going to be coming out. It's going to be coming out. It's in peer review. And so therefore I wanted to, take the time to really share it well. And so, I guess without further ado, let's get into it. The paper is titled Clinical Research Framework Proposal for Ketogenic Metabolic Therapy in Glioblastoma. And it's interesting. They'll talk about why they picked glioblastoma and also how it, is likely going to work for all cancers. It's just they wanted to hit glios because they're some of the most deadly and aggressive and terrible cancers. And so they said, if it's going to work on this, it's very likely going to work on anything. And so that's why they picked that. Okay, so this is the abstract, and I think that it would not be ultra helpful to read the abstract at this point, just because we're going to be going over the actual paper contents. This was actually, I clipped it off of the website for this BMC Medicine, because I think this publication was put out on their website before it even got put out in PubMed. So that's why it looks a little bit different than normal when I put out abstracts. So this is the initial portion of the paper, and it says here that cancer is a mitochondrial metabolic disease and emerging therapeutic paradigm. I skipped over a lot of the stuff that it talked about as a prelude to this, because it was talking about cancer as basically being known as a genetic disease, and kind of like talking about that, how there was problems with that. And then this is where they talk about, cancer as a metabolic disease. And it says here that 2 major biochemical processes exist to generate energy in eukaryotic and or animal cells or plant cells. And substrate level phosphorylation, SLP, also known as fermentation. It's probably also for some people known as glycolysis or the Warburg effect. And then mitochondrial oxidative phosphorylation, or OXPHOS, via the electron transport chain, induce chemiosmosis. Non-tumoral cells, normal cells essentially, are metabolically flexible. In the presence of oxygen, OXPHOS is sufficient to supply most of the energy requirements in a highly efficient and regulated system. Relying on SLP or glycolysis or kind of Warburg or anaerobic metabolism only under certain physiological conditions. Conversely, SLP can produce energy in the cytosol through this. I never heard of this pathway, but the glycolytic pathway. And in the mitochondria, the succinyl-CoA ligase reaction in the TCA cycle, independent of OXPHOS. Cancer cells, including GBM or glioblastoma multiforme, are largely dependent on the SLP flux of glucose and glutamine through the glycolysis and glutaminolysis pathways, regardless of the presence of oxygen. So they're kind of starting to lay out, how cancer cells' metabolism is different from normal cells. Our normal cells, we have metabolic flexibility, and we can live on proteins, carbohydrates, and fats, all of those things, whereas cancer cells cannot. They are specifically reliant on glucose and glutamine for their survival, for their bioenergetics, and their biosynthesis as well. And it goes down further. It says that insufficient or dysfunctional oxidative phosphorylation, or not normal mitochondrial respiration in cancer cells, as compared to normal cells, is hypothesized to arise from the well-documented and universal abnormalities in number, structure, dynamics, collective functional efficiency of mitochondrial populations. And we've had a chance to go into mitochondrial dynamics quite a bit. Have a whole kind of micro series on it, where it'd be fission and fusion, mitophagy, or mitochondrial associated autophagy, or mitochondrial biogenesis, and as well as multiple quality control mechanisms. And in biology, it's generally accepted that structure equals function, right? So if you have structural mitochondria that are damaged, you're going to have dysfunctional mitochondria, and that's going to lead to collective inefficiency of the mitochondrial population. And one of the things we have not really had a chance to talk about much in our time together is mitochondrial redox, and how that imbalance of redox really leads to kind of a snowball effect within destroying mitochondria. But to our knowledge, there are no models of cancer that retain regressive and limitless replicative capacity in simultaneous absence of glycolysis and glutaminolysis. So they've really doubled and tripled down on this, because they have, I've seen it myself, where Seyfried has got pushback from other, people on live streams, or not live streams, but podcasts, and they've been, well, what about prostate cancer? What about this cancer? What about this cancer? And they said there are no models of cancer that retain the aggressive and limitless replicative capacity in the simultaneous absence of glucose and glutamine, basically. Despite substitution with non-fermentable OXPHOS fuels, aka ketone bodies, fatty acids, pyruvate, lactate. So some of you may be aware of that there's an idea that there's something called the reverse Warburg effect, where the adjacent cells to these cancer cells act as a synergy to try to take the lactate that's not getting, the pyruvate that's not getting used by the mutant mitochondria, or the cancer mitochondria, and putting it back through a different pathway. And they're saying that despite substitution, if they give these cancer cells these other things, as recapitulated by essential nutrient constraints in cell culture, they don't see the growth, they don't see the limitless capacity, the aggressiveness that they see when they give glucose and glutamine. That glucose and glutamine have a special place within cancer. And similarly, neither basic nor clinical research to date supports the notion that tumors with certain mutations, whether it be BRAF or others, can effectively metabolize fatty acids or ketone bodies to maintain constant growth after effective dual targeting of glucose and glutamine, even if they do so over a short period of time. I think this is critical to teach, because I think that, and I don't think anybody's like not well-meaning by all means, but like there are a lot of people on the interspace, the internet space, that believe that you have to like shut down all areas of metabolism in order to have success. And I don't think that research supports that. I think it makes sense logically, but you got to leave something open, for your normal cells to be able to use. And we know that there is a problem with metabolic flexibility within normal cells versus cancer cells. And that's kind of like how we can survive while we take care of the problem. It later says here that to avoid these issues, we identify respiratory insufficiency or oxphos insufficiency as the therapeutically exploitable fact that cancer cells, unlike normal cells, appear unable to proliferate exclusively via oxphos when SLP is absent. So what does that mean? It means that they've found that this is the Achilles heel, right? The fact that cancer cells cannot grow and keep growing and proliferating even with oxphos intact, or whatever's left of oxphos for these damaged mitochondria. They need this Warburg effect. They need this substrate level phosphorylation. They need these other fuel sources in great quantities. 10 to 30 times is what I've found in the literature compared to a normal cell. Not by the relative degree of mitochondrial function they may still retain. Residual oxphos is a quantifiable category, but from a purely utilitarian point of view, it may not be able to support long-term proliferation in the absence of sufficient SLP flux, representing a targetable difference between non-tumoral and tumoral cells. So what Thomas Seyfried is doing, as well as Thomas Duraj and everyone else that's involved in this paper, God bless them for putting this out, is they are trying to really leave no room at all for skeptics to say, oh, well, what about these ketones, or what about this this oxphos is still kind of working here. It's 100%, but it's still, to some degree working. And they're like, no, this is not enough to stay alive or to continue uncontrolled growth. However, from a translational perspective, attaining a sufficient level of nutrient stress in vivo will likely require whole body physiologic adaptations, recapitulating fasting metabolism, as well as pharmacologic interventions, metabolic inhibitors, reducing the effect of ATP, biosynthetic output of glycolytic and glutaminolic pathways, even if the metabolic. What is this saying for me, at least, is that, so we know that in a petri dish that these cancer cells, cannot survive with the absence of glucose and glutamine. But that what he's kind of saying here is from a translational perspective, aka taking it from the bedside, or from the bench to the bedside, from the clinic or the research laboratory to the actual like clinic or to the hospital. That translational perspective is that to put that kind of nutrient stress on an in vivo or a whole person, will require probably more. It's going to be more difficult. So I think what he's trying to dispel here is that a ketogenic diet, okay, even the best framed ketogenic diet by itself is not enough. Okay, they're talking about using metabolic inhibitors, okay, fasting, etc., as a way to kind of like tip the scale in your favor. And I think that they have a pretty cool graphic that I pulled. Let's see if I can hide this so I can see this better. So they have a pretty cool graphic here. And so this is what would be a non-tumor cell, right? We have a regulated amount of transport of glucose. That glucose, is going through glycolysis. Pyruvate, which is the end product of glycolysis, is normally going to get put into the TCA cycle inside the mitochondria. That's going to do, to convert to the necessary components, NADH, FADH2. It's going to get put into the electron transport chain. And then there's going to be oxphos, oxidative phosphorylation. And it says sufficient, right? Limited SLP flux, very small print there, sorry. And you're going to have a small amount of amino acid, like oxidation. Those are called glucogenic and ketogenic amino acids. and then very small amounts of lactate made. This is what they call anaerobic metabolism. So unless you're sprinting or unless you're doing, something really crazy exercise wise, you're not going to be producing a lot of lactate, and not for like an extended period of time, right? Like it's going to shut off at some point unless there's something really wrong. Well, in cancer cells, we don't have the same limitations. We have 10 to 30 times more glucose coming in. It's not regulated glucose. Where we have the glycolysis machinery has been like supercharged. Like they've upregulated all the enzymes, they've upregulated everything. And there's no feedback really mechanisms too. And so we have glycolysis, like uncontrolled glycolysis. Well, the issue is the mitochondria are broken, number one. There's also, metabolic switches that are flipped, which we've talked about in the past, like PDK, for example, through the influence of hypoxia-inducible factors. But what we're doing is we're making a bunch of lactate, right? The lactate is like never ending. And this lactate then sets up the TME, or the tumor microenvironment. So, and it's like a feed forward mechanism. So what he's basically showing here to folks who maybe, are not quite on board with the metabolic theory of cancer is they're trying to make it like pretty crystal clear here that these are like, there's clearly two different mechanisms here. And this mechanism here is something that we can take advantage of, because these normal cells, they can do ketosis, they can do beta oxidation, which is fat metabolism. They can do other amino acids, and they can survive because their mitochondria, they work. Okay. And so they're trying to highlight that that's not the case for these cancer cells. Yes, I see the comment, light chain. So let me see if I can go to the next slide here. So what it says here is that regrettably, standard GBM therapeutics, glioblastoma multiforme therapeutics, are not designed to take advantage of metabolic vulnerabilities of cancer cells. Instead, they focus on DNA repair mechanisms. The same, genetic, theory of cancer that's been exploited for a long, long time that's not really shown the results that we want. In fact, as an unintended consequence of non-specific cell damage, radiotherapy has been shown to induce detrimental metabolic changes and inflammation in the tumor microenvironment, impacting the phenotype of recurrence, which should be weighed against the desirable short-term cytotoxic and immune potentiating effects. So just to break this down so we all understand, what they're saying is that the current standard of care does not at all take advantage of the metabolic theory of cancer at all, right? It doesn't use the metabolic vulnerabilities of cancer. Instead, it focuses on DNA repair. And what they mean is that when we are taught is that cancer is an uncontrollable, growth machine. And of course, like the genetic material being replicated is critically important in that process. And so, well, heck, if we can just stop DNA repair, or DNA replication and DNA repair, then we're going to have a huge benefit. Well, the problem is there's unintended consequences of that, because normal cells require DNA replication and DNA repair, right? So there's non-specific cell damage that's happening via these mechanisms. And radiotherapy, in fact, has been shown, or radiation therapy has been shown to induce detrimental metabolic changes and inflammation in the tumor microenvironment. So basically what they're saying is that although you get these short-term benefits of like killing a bunch of cancer cells, because radiation is going to kill a bunch of cancer cells, it's also going to kill a bunch of normal cells, but it's also going to lead to tumor microenvironment changes that creates kind of, or sets up for a phenotype or a type of cancer that is known to recur, or is going to recur because of this extra inflammation and these other, things. And, Seyfried talks a lot about how, like, and it talks about later in here, like talks about dexamethasone and corticosteroids. But, when you're giving these therapies that like raise blood glucose, through normal mechanisms of stress, then that's going to, not be favorable for a long-term outcome, because you're basically trading short-term gains for the lack of long-term gains. And that's what we see in clinical practice, sadly. And I think I didn't put any highlight on this because I wanted to read the whole thing. So while conventional chemoradiation in GBM are well-intentioned, not addressing the unique characteristics of cancer metabolism may hinder their long-term effectiveness. Given the emphasis on patient autonomy in contemporary medical ethics, we advocate for well-informed patients to actively participate in their disease management, fostering supportive follow-up care for suitable clinical trials and complementary therapies. Therefore, to reach a broader patient population, novel evidence-based treatments must be developed, tested, and accepted into standard clinical guidelines. In pursuit of this goal, accumulating evidence that targeting glycolysis and glutaminolysis while transitioning the patient's whole body physiology into therapeutic ketosis could be an effective strategy, effective and translational, viable anti-neoplastic strategy. Winter and colleagues coined the terms ketogenic metabolic therapy, or KMT, to describe the systemic metabolic changes induced by a very low carbohydrate ketogenic diet, calorie restriction, and or fasting. And I think that what I would say about that is, stepping back, when most people have a diagnosis of cancer, at least in my experience, and I see it all the time, unfortunately, is that, someone comes into a hospital, if it's like initial diagnosis, and it's either the presenting finding or it's an incidental finding. So I'll give you an example of both. Like, someone comes in with abdominal pain and has some blood in their stool, and they get a CT abdomen and pelvis, and it shows a obstructing tumor in their colon, right? That's a presenting finding. You present with a complaint that leads to a test that leads to a diagnosis. Maybe that doesn't make the definitive diagnosis, but that gives us a high likelihood of understanding like what's going on with that patient's abdominal pain and also the blood in the stool, right? But let's say hypothetically someone comes in with a pneumonia or a cough or shortness of breath, and they get a chest X-ray or a CT chest, and they find a pneumonia, or they find, I don't know, something else that's not cancer. But then in addition to that, you find an incidental finding of, I don't know, a metastases in a bone, like the spine or something like that, because it's like, in a CT chest, you're going to see the thoracic spine and the cervical spine, or you're going to see a big lung nodule or something like that. And that's like an incidental finding, right? They didn't come in for that. They came in for something completely different, but because they got an imaging test and then you find it, you're kind of like, well, you are obligated to work that up, at least offer it to be worked up. And so my point is that a lot of people get diagnosed and in a way that is like completely overwhelming for them, and in a way they weren't maybe expecting either. Maybe they had some expectation if it's like they lost a bunch of weight, and I don't know. So there's probably some conditions that led people to believe I probably knew I had cancer. I just kind of put it off, getting it checked out. But some people are completely blindsided, right? They come in, I think they're constipated, and they have metastatic cancer, right? And so my point is that, people aren't very well informed or even given a chance to get well informed, right? Because before you know it, you got surgery in there, you got oncology in there, you got radiation oncology, you got whoever else, and you're not even really giving a chance to digest what's actually happening. And there's going to be times when it's probably unavoidable. That's probably very unavoidable in a lot of cases, but not probably most cases, right? Most cases, probably not. And, these days, at least in the facilities that I've worked at, we're not starting chemotherapy in the hospital, right? They're going to get genetic testing. They're going to go and start as an outpatient in some cancer center, infusion center or whatnot. So what they're trying to say here is that given that we're trying to have this new focus on patient autonomy, what does a patient want to do? What values do you have? Do you want to be on chemotherapy? Does radiation sound like a good idea for you? Let them get informed. And that's going to take effort on the patient side, but also on the provider side to explain these other things that are potentially treatments, right? Which is not happening, on a large scale right now. And then I would say that, then they need to have a medical team that is supportive of alternative views, right? It's not just you bring in a ream of paper to the doctor's office and they throw it in the trash and say, cancer doesn't thrive on sugar, which we know it does. It's got to be a supportive, whether that's another doctor or another practitioner that's able to provide those kind of things or not, but they think that needs to be part of the standard of care, is having these other views, which I completely agree with. Let's see here. Probably. I mean, it depends on where the surgery's at, if it's a brain surgery, maybe it's not the least damaging, because that's not exactly, craniotomy and tumor resection and digging into potentially healthy brain tissue, of course, is not the goal, but there's always a chance for, bad things to happen with that. So yeah, I would say surgery probably is the least damaging, but it really depends. Probably a lot of factors. Probably a little bit too predetermined. Probably can't really say that. It'd probably be a case by case basis. All right. So in the current framework, KMT, ketogenic metabolic therapy, is redefined and expanded as an umbrella term that includes long-term dietary, physical activity, and lifestyle modifications requiring objective, measurable biological outcomes, combined with pharmacological targeting of glycolysis, glutaminolysis, and the tumor microenvironment, which is interesting because you would think that ketogenic metabolic therapy would just be a ketogenic diet and fasting. But what they're saying is they want KMT to be actually an umbrella term that encompasses everything to do with basically this type of a lifestyle, including physical activity and even pharmacologic interventions as being part of ketogenic metabolic therapy, which I think is interesting. The next thing I thought that was interesting was that it is important to mention, however, that dietary changes alone are unlikely to control tumor progression in most patients. I think this is like a pearl, because some people, think that all they got to do is be on a ketogenic diet. And I think that's a huge step in the right direction, but it's not the entire be all end all, right? And it says here that, from them themselves, they don't believe that it's going to, for most patients, control tumor progression. While rigorous calorie restricted ketogenic diets and fasting may be effective in targeting glycolysis, insulin, and growth signaling, they do not adequately inhibit glutaminolysis, aka glutamine is a non-essential amino acid, which means your body can make its own. So being on a ketogenic diet and fasting, unless it's like extreme levels of fasting, probably is not going to really have much of an effect on glutamine. Although most agree that the need for combination approaches. So I highlighted that because, I think that one of the reasons why, a lot of these therapies, which have been studied, whether it be 2-deoxyglucose, DCA, whether it be DON, whether it be a ketogenic diet, among many other things, are not as effective in a study, right? In a controlled environment, is because they're not leveraging, the entire cancer metabolism, like it says here. It's not taking advantage of what we know. It's just looking at one thing in a vacuum and saying, oh, that's not very effective, or it's little effective at all, or not effective, when if you put it in combination, it very likely will be a much different story. We acknowledge the pleiotropic effects or multiple factorial effects of dietary ketogenic metabolic therapy may be equally mediated through decreases in growth signaling, insulin, IGF-1, AMP kinase, PI3K, AKT, mTOR axis, immune response, post-translational epigenetic modification, gut microbiome, and or regulation of systemic hormonal milieu, rather than direct suppression of ATP generating pathways. So I think this is important to note, because I think that, myself included, I thought that when you were on a therapeutic ketogenic diet, it was all about glucose, glucose, and glucose. And what they're finding is that there are multiple mechanisms of how this diet affects cancer. And these are talking about some of these things, like insulin, as a pro-growth hormone, IGF-1, very pro-growth hormone, AMP kinase, nutrient sensor. These are also nutrient sensors. This axis, PI3K, AKT, mTOR axis, are all nutrient sensing pro-growth pathways. And then you have improvements in the immune response, epigenetic modifications, changes in the gut microbiome, or the bacteria in the colon, hormone not just suppression of ATP. And I think what's kind of missing here, sort of, is also the glutathione piece of it too. However, it kind of probably talking about it here. We're talking about redox requirements. But however, we argue that the bioenergetics are interconnected with all the above, with major relevance for cell viability under metabolic stress, while intra and extracellular growth factors and biosynthesis may be determining of maximal proliferation, assuming baseline viability, thus ATP sufficiency. So what they're saying here is that although these cancer cells, they require these growth pathways, they require all these things, they still believe, in their view, and that's okay. They're experts, that they believe that the ATP is limiting thing is actually the most important of all of them. And it later says that while we hypothesize that neoplastic cells are comparatively more susceptible to metabolic stress due to substrate level phosphorylation dependency, mutational burden, and dysregulated growth itself, we aim to minimize off-target effects by following a press-pulse therapeutic principles where drugs with a narrow therapeutic index, such as cytotoxic agents or metabolic inhibitors, are carefully dose escalated and applied intermittently on a metabolic priming dietary ketogenic metabolic therapy baseline. So it's a lot of stuff there. What they're trying to, what I took from that is basically that we're going to try to minimize killing the normal cells. We're going to try to focus particularly on the cancer cells and SLP dependency or Warburg dependency, right? And we're going to use the baseline, the foundation would be the ketogenic diet, therapeutic ketogenic diet, with additions of medications or supplements or whatnot that are going to inhibit metabolic pathways in a dose escalated way. That way we are not, damaging, because there's potentially harm that can be done with some of these things. There are side effects of some of these medications, including DON. Is everybody keeping up so far? We're about 30 minutes in. I got started a little bit late because I had some technical difficulties. So far, pretty solid paper, right? I think everybody can, who's interested in this kind of stuff is okay, this is looking pretty good. So importantly, while this approach was developed primarily for GBM, glioblastoma multiforme, primary brain cancer, the mechanistic basis should be applicable to all malignant cancers exhibiting SLP dependency on glucose and glutamine as defined above. So I think this is another pearl here, right? So although this paper that came out a couple days ago is talking about primarily GBMs, the mechanistic basis should be applicable to all cancer, okay? All cancer. In this case, GBM was selected due to poor standard of care outcomes and ethical considerations, as well as potential benefits of therapeutic ketosis to seizure management and intracranial edema, rather than intrinsic bioenergetic characteristics. So one of the, how do I say this? When you have a tumor in the brain, there is a lot of times there is what they call vasogenic edema or swelling around the area of the tumor, which can by itself kill you, basically, put pressure on areas of the brain and lead to herniation and stuff like that. And then the other kind of thing that can happen with any kind of seizure focus, and a big tumor could be one of these, is seizures. And, if anybody knows the history of the ketogenic diet was actually designed for, people who had seizures before we had anti-epileptic drugs and people who were refractory to anti-epileptic medication at that time. So they're saying that although, we think that the major, benefit to a ketogenic diet for GBM in particular is the bioenergetic characteristics and taking advantage of the Warburg effect and, extra glutamine utilization, there's also secondary effects of seizure management and lowering of, cerebral edema, basically, or brain swelling. And it says later here that in general, an isocaloric or a eucaloric, or basically, in not any calorie deficit or a surplus, ad libitum ketogenic diet is not synonymous with ketogenic metabolic therapy. So this is where I've got into, maybe some, I don't want to say arguments by all means, but definitely kind of some heated debates in some cases where people are saying, you can't restrict people's, diets, you can't put people on calorie restrictions. And, I would say that, number one, it is an N equals 1, it is between you and your doctor, whether or not you need to be on ketogenic diet, or, any kind of diet or any kind of calorie restriction. But what they were saying is that, just even if your GKI is good, right? Even if you're in therapeutic ketosis and just eating whatever you want for as much as you want, is not what they're talking about. It is not part of ketogenic metabolic therapy. Now, for some people, again, nuance is everything. This is where, I think it really makes a lot of sense to work with people. a professional to go through this with you, because, obviously you don't want to be on a restricted diet if you're like, cachectic or like very, very thin, or you've lost a lot of weight. Maybe a eucaloric, where you're not, at least not losing anymore, would be a benefit. Or maybe, like it talks about later, it talks about maybe using kind of like almost a press pulse within caloric deficits, where you like have a deficit for a period of time, and then you either have eucaloric, or you even go to a slight surplus as a way so you don't lose so much weight. These are strategies that are going to have to be built, over time, and it isn't N equals 1. That's why a paper like this is like excellent, because it's going to give a very general overview of what ketogenic metabolic therapy could be, right, as a standard. But at the same time, like, everyone's different, what their dietary preferences are. Are you vegan? Are you a carnivore? Are you somewhere in the middle? Are you very overweight? Are you very underweight? Like, are you at a good weight? Like, these things are gonna, do you have nutrient deficiencies? You need extra this or that. So like, there are things that need to be taken into account here. And it says here that as such, the glucose ketone index, or GKI, was developed as a unifying biomarker for assessing biological compliance and outcomes in brain cancer. Hello from Lima. I'm guessing Lima, Peru. Hello from Florida. So what I would say is that the GKI is a wonderful tool. I would say for a lot of people who are trying to do metabolic therapy, it's a very frustrating tool, probably, because getting your GKI where we want it to be is not exactly easy all the time. Hello from Mumbai. Wow, that's a long ways away. All right. What I would say is that the GKI is a way to basically stratify, are you really in ketosis, or are you not? Because a lot of people from Germany, hello. I would say that there's a lot of what people have in their mind of a ketogenic diet and what works in real life. And so I do think this is genius, this GKI, because it kind of cuts through the noise, and it's like, okay, are you on it? Or are you not? You know what I mean? And if you're not, what is in your environment that's affecting your GKI? Because we know that stress and light and all these other things can affect GKI, but also what is in your diet, you know what I mean, that's affecting your GKI. What nutrient deficiencies do you have? What toxins do you have? There are a lot of things. This is where I think functional medicine, integrative, other medicines can be really helpful, because I would say that a big majority of my functional medicine training was about, insulin resistance, diabetes, helping reverse that. And we have a lot of strategies that can be used to help with that, right? And, there's even newer research talking about how, like, red light therapy or photobiomodulation can lower blood glucose area under the curve, when you have the same meal. Pretty cool. So there's a lot of cool stuff you can do to affect the GKI. But this is where, again, working with a doctor who kind of like knows how to do it, or how to help you with that, probably would be very helpful. So this is a pretty cool graph. And it'll probably take a little time to get through this. So basically, what they're calling therapeutic zone ketosis is, less than 2 GKI. And I think ideal, what I've seen over and over again in papers, is that ideal is probably closer to 1. That may or may not be able to be, achieved through diet alone. There, a part of this is going to be, utilizing, exogenous ketones as well as MCT as a way to boost ketones and kind of help your GKI. What I would say is, this is probably a good time for this, is that I talked to someone who's very well known in the space, and I'm going to leave his name out of it because I don't think he wants me to use his name, probably. But that being said, he told me that from his experience, and this was a hard pill to swallow for me too, okay, is that people who have a blood glucose, he says it doesn't matter how many times you do HBOT, how much DAN you're using, doesn't really matter. If you have an average glucose above 80, you're not going to succeed with ketogenic metabolic therapy. Now, I would like to think that my protocol that I put people through is much more comprehensive and would have a better chance of doing well despite that. But that being said, that was a pretty scary, like, factoid for me, because that's a tough one to achieve, continuous blood glucose, or average blood glucose of less than 80. And having the low GKI as well, that's not easy. I do empathize with that. So what they have here is kind of have phases, right? Where you have the ketogenic diet, metabolic therapy, or becoming keto adapted, over a period of about 2 weeks. You're in therapeutic. You could do some therapeutic fasting again for the right patient, but they're showing what the GKI is going to do when you're in that, where your ketones are going to go, where your GKI is going to go, because if you're therapeutic fasting, maybe there's times where you're not compliant and you're going to, you see it go backwards, where the GKI is up and the ketones are just completely out of ketosis. But the goal is to kind of get the hang of it long term and be in a sustainable situation. Now, I think, again, this is talking about GBM and applying it to other models of cancer. And I would say that me as a doctor, like, I would probably not want people to be or have to be in therapeutic ketosis for the rest of their life. Now, I think that if you were a GBM patient and you had a very poor prognosis, sadly, and it meant that you had to be on ketogenic diet, metabolic therapy, like, for the rest of your life, like, in order to, like, achieve, like, NED, or at least, like, giving yourself, God willing, like, a lot more time on the earth, then I think it would be probably a small price to pay. But at the same time, like, it doesn't make it easy, and I think that my goal is slightly different than Seyfried. This is where I, like, diverge a little bit, like, from them. I would say that I'm a little bit more like Dr. Cruz in this mind. Like, you can't get well in the same environment in which you got sick, type of a thing. And we're like, if you're not changing the environment as well, like, I can put you on the best press pulse protocol ever, but if you're not changing the environment that led to cancer, you're likely going to have a recurrence, in my opinion. And so therefore, it makes sense for me that if you change the environment radically, and you may not need to be on, I guess my point is, you may not need to be on a ketogenic diet the rest of your life. That's what my hope would be, or at least maybe you would go through, like, phases where you do, like, ketogenic diet for, like, a couple of months per year or something like that. Kind of like, if anybody's heard of deuterium depletion therapy with Gabor Sommelier and Laszlo Boros, they talk about how, during therapy, you're on a deuterium depleted therapy for a period of time, like a long period of time, maybe like a year. But then, like, after you're, like, in a remission or NAD type situation, then, like, doing, like, 3 months per year of deuterium depleted water or something like that. So that's kind of what I would foresee. Maybe, again, too early to say, but, like, this is what I would say, like, would maybe be a goal where you, like, okay, 3 months of the year, like, you're fasting, you're monitoring your GKI, but you're not maybe the rest of your life. But maybe that's more difficult. Maybe being on a ketogenic diet and tracking GKIs, or at least, like, like, having a hold on where you're at, is more sustainable, because it's not like you're going to do this kind of diet for this many months and then this kind of diet for another period of time. I don't know. That's going to be between your doctor also. Okay. So going forward, the ketogenic diet is defined as a dietary pattern that is very low in carbohydrates, typically less than 20 grams per day, which depletes liver glycogen and initiates ketogenesis, and then adequate and high quality protein sufficient for muscle maintenance without excess contribution to endogenous glucose production. So some amino acids are ketogenic, some of them are glucogenic, which means that they can be used to make glucose through gluconeogenesis. And so therefore, what he's trying to say here is that, this is not a high protein diet. This is a adequate protein diet, just enough to hopefully maintain muscle mass. I don't even think, frankly, that, even enough protein will probably maintain muscle mass. If you're in calorie restriction, you're going to need to exercise, you're going to need a stimulus, to maintain the muscle mass. And, if you look at, like, competition bodybuilders and stuff like that, like, if you were to look at, or people who are in fitness, like, if you put them on, like, an ultra low, diet, calorie diet, and you don't have them exercise, they're not going to maintain their muscle mass likely. Maintaining muscle mass is just as much, probably, if not more, about the stimulus to your muscles than it is to the amount of protein. But you got to have the amount of protein to maintain. I agree with that. And they're basically saying that if you overdo protein, you can contribute to excess glucose production through gluconeogenesis in the liver, right? So we don't want to contribute to that. And that's going to be, again, case by case basis, because, you may be one person A may be able to handle more protein than a person who's not, able to handle more protein, maybe more protein for them. And it's also going to depend on the source too. Like, this is where I think diet quality is really important, because if you have, hey, from Texas, it's a little bit closer than Mumbai or Lima. Yeah. So I would say, probably, to be honest with you, probably weight training a couple times per week. And I don't think it has to be weights. I think it's just resistance training, to be honest with you. I think bands are excellent. Even like rebounding and things like that is considered resistance training in some way. I'm a little more classic. I would say that I would probably want to do some, like, I would want to get my steps in, for example, like per day, like 10,000 steps a day. But I would also highly consider, if you're able to, resistance training, a couple times per week as a way to maintain muscle, but also, as we talked about in other videos, that's a way to actually steal away glucose and glutamine from cancer cells, right? All right. So the baseline dietary strategy is to follow a macronutrient distribution that facilitates ketogenic adaptation, preserves lean body mass (LBM), and preserves and maintains an adequate micronutrient balance while keeping sustained daily GKI values below 2, ideally near 1. Yeah, that's a good point. Yeah, protein powders, I would say, probably would be not a good idea for most people, because, especially like hydrolyzed proteins, where basically the amino acid chains are actually like broken down, they're going to probably have a much more effect on your insulin levels as well as glucose levels. So I would say probably whole food always for these kind of, unless it's like impossible, but more often than not, probably whole foods would be the best. Absolute blood glucose levels should be consistently below 90. I've heard, even in clinical practice, that it's probably got to be less than 80 consistently. Lower the better. This is an arbitrary, statistically derived cutoff that has been associated with improved survival, but does not define known biological constraints. This is where I have to, again, push back that people in the space who have been treating people with metabolic therapies, in their experience in clinical practice, again, this is like the lab versus clinical practice, is that really the lower is probably better. Okay, 90 is probably not going to be acceptable. Maybe in the beginning, when you're like really becoming, keto adapted, or maybe you used to have a lot to weight to lose, or you have diabetes or prediabetes, then maybe that would be the case. It's probably going to be much better than maybe where you were before, but it's not going to be probably long term. We want it to be lower than that for sure. Let's see here. And then it says preclinical and clinical evidence suggests that patients should aim for the lowest physiologically safe and sustainable glucose and insulin levels. I agree fully with that. And that's going to depend, on your tolerance, on your n equals 1, because let's just be honest, if you have diabetes, depending on how bad it is, patients can feel hypoglycemic, like the exact symptoms of hypoglycemia at like 150 or 130, and that is not going to be ideal for our metabolic approach to cancer, right? So like, you got to be very patient with yourself if you're in that position, don't slam yourself down to 60. You're going to have problems, so this is where working with the doctor is important. From my understanding, so if you listen to the question was, how significant are those 10, milligrams per deciliter? And I believe they're much more important than they are now than I did before. Okay. I used to think that as long as your GKI was good, you're getting the majority of the benefits, because if you read some of Seyfried's earlier papers, he was saying that the majority of the benefit comes from, increased ketones and lower insulin levels, which they do, say here in this paper that they still agree with, but it seems like they've really softened their view on that. And they're now thinking that it's really is, glucose more. And that's why I think that they do say that preclinical and clinical evidence suggests that the patient should aim for the lowest physiologically safe level of glucose and insulin levels, right? Because I do think that there's a big difference that is made. So I'm standing by that. You probably do want it to be less than 80, ideally, consistently. Again, if you eat something, it's going to go up, no matter what you eat to some degree. But you want it to be average less than 80. That's what I'm getting from colleagues, in the field. And I want to honor that, because if I tell you, oh, don't worry about it, as long as your GKI is 1 and your glucose is 100, then I could be doing harm. And I don't want to give you that information. Okay. So calorically restricted KDR reaching GKI targets while preserving muscle mass. This is what this section is titled, and it says that the classic ketogenic diet was intended to be eucaloric or unrestricted ad libitum to allow for appropriate maturation of pediatric patients with epilepsy. So remember, historically, the ketogenic diet was for these pediatric, epileptic patients who were seizing all the time. We didn't have good therapies. And so we didn't want these, kids to lose weight, so they were just like, look, as long as you're in ketosis, the ketones will help you, with your seizures. And we don't want you to like mess up your growth, right? So that's how they were originally designed. However, a failure to reduce proliferation could be a consequence of persistently elevated glucose availability, endocrine and or growth promoting signaling due to energy surplus despite shifting to a ketogenic state. So obviously there's like ideal, which is like a therapeutic ketogenic diet that is calorie restricted, but it may not work for you. And so there may not be as good of effects if you're, not in a calorie restricted diet, or at least a eucaloric type of situation. And I think that's going to have to just be, it is what it is type of a thing, because obviously if you're like, again, cachectic, we're not doing any good for you if we're, malnourishing you to the point of like, to that point. Calorie restriction, independent of macronutrient composition, increases metabolic pressure on tumor cells by modulating nutrient sensing pathways. So this is I think also a pearl. Okay, so there's these nutrient sensing pathways, like insulin pathways. There's the PI3K, AKT, mTOR pathway. There's the AMPK or AMP kinase pathways. Those pathways are critical. And what they're saying is that calorie restriction by itself, even if you were on a high carbohydrate diet, okay, calorie restriction by itself will put pressure on tumor cells by modulating these nutrient sensing pathways, which I think is important to note. And I think it's good to put. This paper is really comprehensive. I think it's really good. What they're saying is that adequate protein levels has either a neutral or minor effects on on ketosis, basically, and insulin signaling, as hepatic and renal gluconeogenesis. And what it's saying is that total protein intake can be started at 0.8 grams per kilogram of body weight. And, let's just do some quick math here. Let's say you were a 70 kilogram person and you were at 0.8, that is only 56 grams of protein per day. Okay, that is not a lot of protein for most people. If you let's say we translate that to eggs, I think there's about seven grams of protein per egg. So that's like 8 eggs per day. That's the amount of protein you're having per day. Not a lot, right? So although we're not talking about like no protein diets, but 56 grams of protein is not very much for most people per day. It is important to emphasize that dietary amino acids cannot be restricted for clinically relevant glutamine depletion, as glutamine levels remain relatively stable through de novo synthesis regardless of diet composition. Physical activity coupled with a low carbohydrate diet as well as prolonged fasting are potential non-pharmacological strategies to achieve transient or chronic reduction in plasma glutamine respectively. So I think this is great. Eucaloric. Yeah, eucaloric means, so yeah, what that means in layman's terms essentially is that, there's a balance, right? So if you eat more than you burn, that's called a hypercaloric state, right? Or I don't know, you would not be in eucaloric state and not a hypocaloric state. So a hypercaloric state. And so when you have more calories in than you burn, we're not a closed system, so it's not exact, but generally you're going to gain. If you are hypocaloric or you're in calorie restriction, right, you are basically taking in less calories than you're burning, right? So then you're going to actually lose weight, ideally. Not a closed system, not perfect, but generally you'll lose weight. Eucaloric means that you're eating the amount of calories that you burn. That's what it means. And so that requires like some evidence and knowledge by yourself, right? So there's a concept called the basal metabolic rate, and there's calculators on the computer for this. And so, for example, like you can actually like do a BMR calculator. It'll calculate your basal metabolic rate based on your age, your sex, your height, your weight. And then what it'll do is you'll see another table like to the side, and it'll say like, okay, well, how active are you? Are you basically like on the couch? Never? Are you sedentary completely? Do you like have minimal activity? Do you vigorously exercise every day, multiple times per day? Like it will, and then what it'll do is it'll actually like, it'll give you like an estimate, of like what your basal metabolic rate is with that level of activity and those other parameters. And then you could say, okay, well, in general, based off this formula, if I eat, let's say it's 2,000, for a simple sake, it's 2,000 calories. That's a eucaloric state for me, right? If I eat 1,800, I'm in a hypocaloric state. If I eat 2,200, more than that's not a calorie restriction. That's more calories than I need to burn, and I will likely gain weight in that kind of a situation. It's not exact, but it's pretty good, So that's what eucaloric means. We're about an hour into this, and I have got 19 of 49 slides. Wow. Why don't I hit one more slide here? Okay, so I think the next, someone actually mentioned this in the chat here. It's easy for the liver to create out of MCT oil, but you might get a stomach upset. Yeah. So probably take it slow with the MCT, and that's why I wanted to dovetail that into this next portion here. Is that supplemental ketones and exogenous, MCT oils can be really helpful at getting your GKI where you want it to be. Ketones, I personally have not had any problems with ketones, like drinking them and giving me any problems. But I do find that MCT oil for some people have, they can give them problems. I can take them, and I haven't had much of a problem. But Dave Asprey kind of has a joke about MCT oils. If you remember him from the Bulletproof diet and stuff like that. And he would talk about how like if you overdo MCT oil, you can have basically have uncontrollable diarrhea. I have not seen that for most people, but it is possible. And I've heard also it's more likely to happen in women than men, believe it or not. So supplementation of medium chain triglycerides, MCTs, and exogenous ketone bodies. MCTs, particularly C8 caprylic acid, are a type of dietary fat that can be supplemented to potentiate liver ketogenesis. MCTs bypass normal fat digestion and diffuse across intestinal membranes and the hepatic capillary bed, where they are readily converted into ketones. And this paper, I would really highly download this paper, read this paper. This paper is really good, and it really does lay out like a lot of very like practical things. It talks about how many you could do per day to help with ketones. Even talks about like particularly C8. This is an area where it'd probably be helped to have some guidance, because if you just go to like any old store or Amazon and get MCT oil, you may get C12, you may get C10, you may get C8. You may not know what you're getting at all. And I think C8 and C10 are probably the most beneficial. C8, I think he talks about here. So I mean, he's really like laying it out for you guys, for everybody, really, for providers and patients alike. And I'll finish here. Is that analogously, exogenous ketone bodies, ketone esters or salts, are a novel dietary formulation that can be taken orally to temporarily enhance circulating BHB or beta hydroxybutyrate levels. Beyond their bioenergetic role, ketone bodies act as a pleiotropic or multiple factorial, signaling molecules with potential anti-neoplastic effects on their own, like aside from being in ketosis, like the ketone bodies themselves and low glucose and low insulin. There's like benefits by themselves. I have a whole video on that, as a matter of fact. I was surprised by it myself, but there's actually anti-cancer effects of the ketones themselves. Elevated blood glucose and ketone levels are typically not found during normal physiology of calorie restriction or fasting. So, I guess what they're trying to say here is that they don't know if let's say you're on like the standard American diet and you're doing ketones, like, are you going to get a benefit? Like, is your body going to know really what to do with that? You're probably going to get some benefits, but you're not going to get anywhere near you would be if you were under normal physiology conditions, which is like low glucose, low insulin, and high ketones, right? Your body knows what to do with that because that's like normal physiology. And it says here that in conclusion, supplementation of MCTs and exogenous ketones can be viewed as a valuable tool to empower patients to modulate their ketonemia, ketogenesis, and gluconeogenesis without being an absolute requirement. Now that's interesting, because if you guys remember, I don't have it in this PowerPoint presentation, but if you remember from the classic graphic that you see from, it says KDR and ketone supplementation as if it's a requirement. And remember, it's like a little line that says like continuous thing. They've kind of softened on MCT and ketones as well. It looks like, this is not an absolute requirement, valuable tool, not an absolute requirement. So pretty interesting how things have changed since that 2017 paper. I don't know if it's this new blood, with that this paper, man, let me just go back quickly. This paper has a bunch of authors. Look at these authors. How many authors there are? And there's like a plus sign here. I didn't push it, but there's many authors, many authors, including Seyfried. Duraj is the main author, Dominic D'Agostino, and many people that I'm not aware of. I don't know the vast majority of these people, as a matter of fact. So this is a really comprehensive paper, and I think I'm probably have to do a part 2 to this live stream, because we're already an hour in and we're only about halfway done. So any kind of last minute questions before I sign off here? While the questions populate, I'm going to say this. I think that what I'm going to end up doing is I'm going to make a little membership within YouTube, and I'm going to do like a monthly hour, maybe longer Q&A for people, and there'll be tiers or whatnot, and then we can have a little bit more discussions. And I'm thinking about, if you guys end up liking this live stream, by the way, this is a way that is kind of good for me in a lot of ways, because I'm gonna trip over words, and I'm gonna it won't be quite a polished product, but for me, like, the editing is killer. I mean, like, I don't mind doing a video. It's easy for me to shoot one, but to actually edit it takes me several hours, sometimes even upwards of like 5-6 hours to edit even like a 15-minute video. So, like, even though this is a longer thing for us, I'll be happy to do these lives if you guys like it. Okay, so a couple questions have come in. How do you find the papers? Can I research this myself? Yeah, just take this title and put it into Google, and the paper will come up from the BMC Medicine, and it may be on PubMed now too. It wasn't as of Friday. Thank you. I really appreciate that. But it wasn't as of Friday on PubMed, but the paper is out. The paper is out. Anybody can download this paper. And I actually suggest that you do, because even though I've highlighted a lot of the supplemental materials in the later slides, we're not there yet because we're just still in the main part of the paper. There are a lot of supplemental materials, and I can't cover them all probably because there's just too many. The paper is action-packed with information. Let's see here. The next question was for ketones. Grams of C15 is like a milligram thing. So C15 is probably not a medium chain triglyceride. It's probably considered a longer chain fatty acid. My understanding is C12 is the longest carbon chain. That's what the C stands for. That is considered an MCT, and even C12 is not a great one for this kind of purposes. C8 and C10 are kind of the best, and even I think C6 is considered MCT. And I was listening to a podcast from Dom D'Agostino not too long ago where he was saying that even C6 is not excellent. It's really C8 and C10. Let's see here. How to time the press pulse and then yeah, that's a great question. That's probably I'll talk about what is presented in the paper. How about that? Not today because we're already an hour in. The next slide, as a matter of fact, where the heck is it? Where am I? The next slide, pretty cool slide. We'll start off on this one next time. Is kind of like how you start to implement this and stuff like that. But yeah, I mean, honestly, the question is fantastic, and it's obviously the most logical question. It's just that I don't think it's been worked out yet. If you want me to be honest with you, I think it's still to be determined, and I think it's not a dodge because it just doesn't exist in clinical practice yet. As it just isn't. It isn't protocolized enough. I think it's still in the beginning phases. I think that I have my own let's say particular, I have my own version of Press Pulse, that I share with clients, but it's still an N equals 1, right, for everyone. And what you can do, what you're able to do, what you can afford to do, because, unfortunately, like this metabolic approach, because it's not it's not approved by the powers that be, and it's not, covered by insurance. It's out of pocket, so like supplements, diets, spot, IV vitamin C, etc. They all are very expensive. So it's still kind of to be determined. And I think even when we have the protocol, it's going to still be an N equals 1. There's going to be variation. Should glutamine suppressant supplements be avoided until the pulse phase? Great question. To be determined as well. I find that these supplements, people use supplements like resveratrol and berberine and stuff like that every day, for other purposes, and they have no problems whatsoever. So my thought is that the supplements probably are not as big of a deal in terms of like being so careful. Whereas like Dawn, or drugs that affect these glutaminolysis pathways that have stronger effects and have more side effects, then I think that those, will have to be pulsed, definitely. But yeah, there's still controversy there too, because as I talked about during my Dawn talk, like the best available evidence, again, Dawn in a vacuum, not Dawn with these other things, not Dawn with ketogenic diets, are a daily dosing. Let's see here. F8 and 10, MCT oil, blah, blah, average glucose 90. Yeah. So if your glucose is still 90 at best with all of those things, you've got some digging to do. You and your doctors got some digging to do, because you gotta figure that out for sure. And I'm not trying to come down on you by all means, but like that is a high priority for you and for me at this point. I had the same issue. Yep. I imagine a lot of people are gonna have the same issue. Insulin resistance is a real thing. It's a big, how many people have diabetes? I mean, that's an insulin resistance issue, right? So like, it's going to be harder for those folks. I don't know if you guys have that or not, but NED tumor markers are normal. So now what? Ooh, that's a great question. Great question. So, well, I don't think anybody knows the answer to that. Number one, I certainly don't. But I think if it was me, I would probably be after I was in an NED situation, I'd probably be aggressive, like foot on the gas for another, 3-6 months. Follow up PET scan, things are still looking good, tumor markers still down or undetectable. Then I would try to try to get myself into be as healthy as possible and never go back to where I was. And that includes diet, but that's also environment. It's everything, let's see here. Dihydroberberine. I tried dihydroberberine. Personally, I didn't like it as much, but I also wasn't doing rigorous testing on it either. So it could be better. I know it better absorbed, but their also doses are less. So like, is it any better? Also, one thing that I would mention about dihydroberberine is that, it doesn't get absorbed very well, but is that part of the beauty of it? Is it affecting the intestinal microbiome? And we know it is. We use it in functional medicine for like killing protocols. It affects the microbiome. So is that how the insulin resistance is improving too, through microbiome? And by doing dihydroberberine and not having any of that berberine getting into the GI tract further down with the microbiome, is that affecting you in a negative way? I don't know. The higher dose side effects there. Pulse. Thank you, Dr. Peavler. Thank you. You're welcome. You're welcome. BEP chemo for testing. I don't know what BEP chemo stands for. Can you is it an acronym? Is it a immunotherapy? I'm not sure. Please specify address gallstones, ketogenic diet, especially with gallstones, gallbladder for a long time. Yeah, great question. So, I don't have a good answer for this. What I would say is that why did your body build up gallstones, right? Like, number one. Number two, is being on a ketogenic diet going to make you worse? Well, there's a high fat diet, right? And the gallbladder is going to contract during a meal. It's going to help with digestion of fats. I don't know. What I would like to know is, does the gallbladder contract more with a high fat diet than it does with a normal carbohydrate diet? I don't know if I can make that argument, So, you're probably at risk of having, what they call cholelithiasis or cystitis, which is where the gallbladder duct gets blocked by that gallstone, or even gets infected, where this is what ends up with how you end up with a gallbladder surgery or a cholecystectomy. I don't know the answer to that. I would say that be careful. Maybe look at, there are ways to like dissolve gallbladder, ducts, or gallbladder stones. I don't pretend to know them right now. Thank you. Right now. So I don't know. I think just maybe be careful is the only, kind of like conservative like thing I would say there. And if you start having more pain, obviously, then you got to do something different, that would be cholelithiasis. If you start having pain and fever, then that's a big problem. That probably you go to the ER for that. But in terms of like just having gallstones, I don't know there's a huge risk. Bleomycin, etoposide, platinum. Yeah, those are heavy hitters, man. I don't really want to comment. I can't act as a doctor here or give medical advice. What I would say is that I do think that this gets into a deeper portion, right? Like I do believe a lot in patient autonomy. So like some people who come to me, they're like, I want nothing to do with the standard of care, and I get a little nervous with that, And then if some people are like, if you wanted only the standard of care and didn't want to do the metabolic side of things, I'd be like, that's not very smart, but I'm still going to let you do it if that's what you want to do, type of a thing. I think integrative, approaches are probably the best, and maybe what they can do is with being on a, ketogenic metabolic therapy, maybe they can use lower doses, maybe they can use chemo at less intervals, something like that, in a way that you can, and as we know, like I've talked about dozens of times through various videos, a lot of these substances we've talked about enhance chemotherapy, enhance radiotherapy, enhance the standard of care, enhance immunotherapy. They dovetail nicely in, so most of these therapies are going to be good to kind of dovetail into the standard of care. So that's of course always a discussion between you and your doctor about if that's good for you. And I know some people will say, well, my doctor's doesn't want to listen to me, and I totally get that. I don't mean to like minimize that, but maybe we got to find someone locally who is going to listen to you, because there are people out there, I am far from the only person who's, talking about these kind of things. There are people who've been doing this for a long time, integrative oncologists, and maybe you don't have one in your immediate local area, but maybe within your state, or maybe within a driving distance, or, something like that. So maybe finding someone who will listen to you and who can help you implement these things. You're welcome from Florida. Man, that's really nice of you to say. I do feel like I'm on a spiritual mission with this. I do. I do think that it's important that I think it's as important that I share this stuff with you guys than it is for you to receive it, believe it or not. Because I think that if you read these papers, as a person who got into medical school who wanted to help people get well, and you read these papers and you see this literature and you don't share it, man, that feels wrong. That feels unethical, So I think that I'd have to at this point share it, and I think that it is part of kind of a spiritual mission. So, anyways, man, you are speaking German, and I have no idea what you're saying there, but I wish there was like a Google Translate thing in real time, because it does on the comments when people give me comments in other languages, I can actually understand. Yeah, so I actually, you guys, I haven't had a chance to even do the micro series on glucose inhibition yet. That was my plan, actually. I was going to do a glucose inhibition series and then glutamine, but then when I did that, I did a poll or something like that, and everybody was like, glutamine. So I changed course. I have a lot to share left with you guys about glucose, so I hope I can make a difference there. Anyways, I think that, hour and 15 minutes is probably pretty good. I plan on doing another one of these to do the other half, or maybe another couple of these to get through this entire paper. I mean, this is a behemoth monster paper. And I mean, look at these graphics. These are beautiful graphics. I mean, these are so great for a presentation or for really hammering home the what he's talking about in this paper. So I hope you guys enjoyed this paper as much as I do. I wish that it was under different circumstances. You were watching this, you probably know someone or are someone who has cancer and you need this for yourself. And I wish it was under different circumstances that you were coming to find this information. But at the same time, we are where we are, and at least we have it now. At least we have more firepower to know how to implement these things. And I do recommend downloading the paper, and I look forward to presenting the rest of this at a later date, hopefully soon, God willing. Okay. Have a good rest of your day. I'm going to answer one more question. Glutamine was more difficult thing to speak on because I think you feel most people on a ketogenic understand. Yeah, I agree. I think glutamine is more nuanced. There's no question at all. Your body can make its own, right? So it's much more difficult to target, and it's unlike glucose, where you can be at a ketogenic diet and be okay. Like you can glutamine is a different beast altogether. Yep. All right. God bless. Take care. Wow, from Latvia. Wow, amazing. Take care. Bye bye.